Hi, Andy.
Hi, Victoria.
Today we have one of our own, a very interesting integrative oncologist, Dawn Lemanne.
And integrative oncology is a new and growing, I hope rapidly growing field.
And one that you've had an interest and a commitment to for decades now.
Yep, and I think Dawn is a great representative of that.
Well, let's get her on.
Okay.
Dr. Dawn Lemanne is a board-certified medical oncologist and a widely recognized authority on integrative oncology. She's the founder, as of 2014, of Oregon Integrative Oncology. Dawn is a graduate of our fellowship program and now serves on our fellowship faculty, as well as serving as assistant clinical professor of medicine at the University of Arizona. Welcome, Dawn.
It's great to be here. Thank you for having me.
Dawn, you have been so innovative in your integrative oncology practice, and you really take pride in approaching every patient as an N of one. What does that actually look like in practice?
Sure. So that is something that I really am very, very interested in and learned a lot about in the Integrative Medicine Fellowship. That was one of the reasons that I went to the fellowship. I was not happy with a protocol list and something that you did this for every single patient based on a diagnosis that was written down, because the diagnoses seemed a little fuzzy to me. And as I went through my career, I found out that, everything in medicine is a little bit fuzzy. And so why not try to focus in on the person who's exactly in front of you? And so one of the things that we do in integrative oncology very, very well, I think, is listen to the patients and hear where they're different from the patient that was in the room a few minutes before with ostensibly the same diagnosis on paper. And I think in oncology, we have been forced to do that because when we follow the protocols exactly for each patient with the same written diagnosis, we get wildly different results constantly. And so I think every oncologist comes to the point where they understand that there's more to this business than finding the diagnosis and then matching the treatment to it. And what this requires on the ground is changing treatment a lot and changing it constantly and changing it in different ways for different patients.
Dawn, where is the field of integrative oncology now? My impression over the years is that the demand for this has been great, but the supply of practitioners trained to practice it is not that great.
So, there are a lot of people from the fellowship who are treating cancer patients with integrative methods. I think there are fewer medical oncologists and radiation oncologists, people who are trained also in oncology itself, who are doing that, but the number is increasing. And this certainly patient interest is driving this dramatically. So you can't find now a large academic cancer center that doesn't have somewhere at least one room that has integrative medicine or integrative oncology over the door. So yes, patient and the focus of those are sometimes, in various degrees limited or expansive, depending on who's there and what their interests are. But yes, it's being driven by patients, and it will only grow. And I think, Andy, one of the things that you taught me and you continue to say is that integrative medicine is going to just become medicine, and integrative oncology is just going to become oncology. And that's very much patient-driven in a good way. And we oncologists are scrambling to keep up. And but that's a positive development, yes. And you're right, there are not the integrative oncologists are few.
Dawn, one of the concepts that I've learned from you has to do with adjusting a patient's treatment protocol in real time based on the evolution of their tumor or their cancer. Sometimes it's called adaptive therapy. This is, I think, a real challenge to the conventional approach. So I would really love to hear you talk a little bit about this. And my understanding is one of the exciting potentials is that it can reduce the risk of treatment resistance.
Oh, so, there are many epitomes, but one of the epitomes of integrative approaches is to think of cancer in a particular patient as an interloper in an ecosystem, with the patient being the ecosystem and the cancer being the interloper. You can think of it as an invasive species, something like that. And that's a vague metaphor. We have to use metaphors to think about this being human. But oncologists, including me, have started talking to ecologists. And I mean literal ecologists, people who study ecosystems and look at the population dynamics within very, very complex systems. And we've taken some instruction from that. And a good example, I think, that everybody will relate to is gardening and putting a particular pesticide on your garden. So in the 1950s, DDT was invented, I believe. And from 1950 to 1956 or so, cotton farmers in the South, the American South, where cotton is the major, to this day, major crop, had a problem with a parasite or some sort of entity called a cotton boll weevil, meaning a boll of cotton, a B-O-L-L. And DDT killed them. First year, they applied this stuff like water to the fields. All of the boll weevils were gone. The farmers would walk through the fields and there's none. That's great. Well, the next year, the boll weevils are back. Put some more on. Okay. This went on till 1956 when they put on as much DDT as they could get their hands on, and the boll weevils just thrived. So what happened? What happened was all of the boll weevils that were sensitive to DDT, who were poisoned by it, died off in the first round. And it was most of them. But there was a small percentage of the whole boll weevil population that was inherently insensitive or resistant to this chemical, DDT. And so those survived and reproduced. And each year you got more and more of them and fewer of the sensitive ones. So we've heard about that with antibiotics, and I don't want to get too much into antibiotics because we've used the metaphor of antibiotic therapy in cancer to our detriment for many decades. We could talk about that later. But we've heard about the development of resistance in germs that we treat with antibiotics and how that's been a problem because of overuse. It's the same issue in cancer within one patient. If you give a drug over and over and over again, at first, the drug is going to look like it's working beautifully. And I'm talking about, let me back up 1 minute here and say that what I'm discussing right now has specifically to do with diseases in the oncology field that are considered incurable today with standard therapy. And these are things like metastatic breast cancer, metastatic prostate cancer, metastatic colon cancer, metastatic lung cancer, metastatic pancreatic cancer. And there are quite a few more. I didn't list all of them by any means, but I'm talking about diseases that are considered incurable. I'm not talking about early stage breast cancer or early stage colon cancer, early stage prostate cancer. I'm not talking about those. Those need to be treated we do have curative treatments for those, so those should be treated in that sense with standard therapy for cure. But if you have a disease that's not curable, let's take metastatic prostate cancer, not curable with current standard therapy. And what happens is that at the beginning, the gentleman will come in with, perhaps widely metastatic prostate cancer involving the bones. Specifically, that's where prostate cancer likes to spread first in most cases. And we can see that on a bone scan. We give them the standard treatment, which is called androgen deprivation therapy. It's a testosterone system blocker. And the bone scans get better over the next 3-6 months. The bone scans completely clear up. The PSA, which is high, goes down, sometimes becoming almost undetectable, and everybody's really happy. But within another 6 months or so, on average, the disease comes back. We say it comes back. What we really mean, what we should say, is that it never really went away. And the reason is it's the same story as with the cotton boll weevils and the DDT. We kept applying the same remedy. We destroyed the treatment-sensitive tumor cell population, and the tumor cells that were left were the ones that were resistant to our treatment, and they've been repopulating the tumor all over the patient's body. So that's a really common scenario. We see that over and over again. And one of the things that, this really, I think this kind of lit a fire under me. When I was in training, one of the things that we would tell patients over and over again, and we said this with a straight face, is we're going to treat you. And this cancer is not curable, but it's treatable. And we're going to treat you. And then we'd say, and when the treatment stops working, we're going to go on to another, So the problem with that story is that, number one, we oncologists just accepted that. We didn't question it and say, well, can we do better than this? Why are we accepting that, the treatment's going to stop working? And the second thing that I didn't go too much into there is that the second rounds of treatments don't work as well. And the third rounds work less well than that. And pretty soon you start having more side effects than benefit, and the story doesn't end well. So those are some of the things that really got me going in this. And what this looks like on the ground in terms of trying to do something different is pausing treatment before we wipe out all of the sensitive cells. Why would we want to do that? Why would we not want to destroy all of the cancer cells, as many as we could, even if they're the sensitive ones? I mean, just destroy as many as you could. Well, it turns out that the sensitive cancer cells actually are doing my job. They're helping to control the resistant cells, which are more dangerous because we can't treat them. So if the resistant cells have a lot of competition for nutrients, waste removal, oxygen, space, everything that they want in that ecosystem, if they have a lot of competition from the treatment-sensitive cells, their population is kept suppressed. In other words, we keep them in a low number. So that's how we do that is we pulse the treatment. And we do that not just, let's give you 1 week on and 1 week off. We actually look at the tumor growth dynamics. And what does that mean? All right, well, prostate cancer was one of the first tumors that this was done in, and for a very specific reason. Most patients with prostate cancer have a beautiful tumor marker called the PSA. And every man over 50 is going to know what the PSA is, prostate-specific antigen. When you go in for your annual checkup, your doctor, will ask you if you want to have that checked. And if you do, here are the numbers that you want to watch for, et cetera. So the prostate-specific antigen is made by prostate cells, normal or malignant. And if you have a lot of prostate cells in your body, you're going to have a high level of PSA that we can measure in your blood. If you have a high level of PSA in your blood, it's likely not coming from benign, normal prostate cells. You likely have a lot of extra prostate cells, and they are cancerous and trying to spread to other parts of your body. So that's what the PSA is. We can measure the PSA dynamics. So when we do adaptive therapy, we measure the PSA as often as once a week. So
wow.
if you have prostate cancer, your doctor may measure your PSA every 3 months, a lot. Well, by then, a lot of things have happened. So we measure the PSA, and we try to keep the PSA, instead of suppressing it and making it go as low as possible, we try to put the PSA down. And these numbers are just to make the math easy right now. These are not the real numbers, okay? So do not do this at home. But if a gentleman comes in with a PSA of, let's say, 100, we'll try to get it down to 50, and then let it go up to 75, maybe back to 100, and kind of cycle it in between there. And we do that by timing the treatment. And one of the things that's made this possible and much more easy is that now there are oral androgen deprivation therapy drugs like Orgovyx, Relugolix, that are pills. You can just take a pill. The usual treatment has been a shot that turns off testosterone production 4 months, 3 months. I actually measure the testosterone level. A lot of gentlemen do not recover their testosterone after 1 3-month Lupron shot until month 5 or even 6. So they're really not, 3-month shots for a lot of people. But if you give them a pill every day that does the same thing, lowers the whole body testosterone system function, you can stop that at any moment. Okay, Mr. So-and-so, your PSA has gone from 100 to 50. We don't want it to go any lower. Let's have you stop your pills and let's let it go up.
So let me pause you for a second, because in so many ways, this is so counterintuitive. And yes. Andy, I'm going to pick on you for a second as my resident ecologist. Can you think of a place that we're doing this in the plant world so that we have a healthier ecosystem? Because you gave such a beautiful analogy, Dawn.
Yeah, I think there are forms of natural agriculture, regenerative agriculture, where you don't wipe out all the weeds or all the things that you consider noxious. You let some of them grow and you wind up having a healthier ecosystem than when you do a monoculture.
Yeah, we have been having a conversation with one of your neighbors, actually, Wendy Johnson, who wrote a book called Kinship Medicine, and she talks about making an effort to live in harmony, not just with the plant world, but also with the animals, including the animals who may be nibbling on your garden. And I think that's an indigenous practice as well, that you don't necessarily rid everything, because there's benefits actually to this diversity of plants and animals.
Well, I think the lesson from using pesticides against insects is very dramatic. That we have made insect predation on plants much worse by our use of insecticides. No question about that. We've bred insects that are stronger, tougher, more damaging than were there to begin with.
So the equivalent of those resistant tumor cells. So Dawn, when people hear these 3 terrifying words, you have cancer, what they're often hoping for next is, and we have a cure. How do people react when you tell them, we don't actually have a cure, and our goal is not to, get you to what looks like a remission, right? Briefly at least, but rather to just suppress to a certain point, turn this into a chronic, manageable disease. I think people are so frightened. Do people go for this?
Yes. So our first patients, we started this, I work with so there's such a thing, an entity called a mathematical oncologist. And I work with them, and we started doing this clinically in about 2017, 2018, I think, something like that. And our first patients were physicians, all of them. And they came in and they said already, we get it. We're going to just wait for resistance and then go on to the next thing. We don't want that. And there were some, very early trials, clinical trials progressing at Moffitt Cancer Center and a couple of other places that looked promising. And so those were the first patients. Now that knowledge has trickled down to people who are not physicians, and they've heard of it. We have a very public patient who's a professor of genetics at the University of Utah, and he and his oncologist are very public about this, that they're using our techniques and advancing them themselves as well for this particular gentleman who has an advanced form of male breast cancer. And he's been doing well for many, many years, presented de novo with metastatic breast cancer, and has been, I think he just got back from a trip to Africa. He's completely active, doing whatever he wants, doing his research, his genetics work, and AI work in genetics, using an adaptive approach that's constantly changing. So we will treat him with tamoxifen for a while, and then we'll stop, and then we'll treat him with some chemotherapy drugs. And not just guessing, but trying to fit the various mechanisms together so that when we treat him with one particular entity the way that the tumor evolves resistance to that entity then makes it susceptible to the next thing that we're going to apply. So, yes, patients do accept this. The thing that's hardest for patients to come to grips with and understand at the beginning is watching the tumor marker go up on purpose when the treatment is paused. That's difficult psychologically. And that's because we're, we don't want to see our quote unquote enemy, if you're thinking about it that way, getting stronger. But, one of the leaders in this field, Dr. Robert Gatenby, whom I think you know, Victoria.
He was a speaker at our conference a few years back. You introduced us to him.
Oh, okay. Well, he was at the University of Arizona for part of his career. So, but one of the things that he says is that, we don't want to play whack-a-mole with cancer anymore, which is what we're doing with our current standard treatments. We want to play chess. We want to be a few moves ahead of it, and we want to drive it into the direction we want it to go so that we can continue to control it. And so that's the idea. And that's, and that's completely from the field of ecology formally. So there's an ecologist who's at the Department of Mathematical Oncology, Integrated Mathematical Oncology, that's what they called it, which I think is great, named Joel Brown, who has spent his career studying ecology and mathematical ecology. And so they develop, the protocols for each patient, how far up to let the tumor marker go, how far down to suppress it before we, remove treatment again, those kinds of things. So it's very dynamic. The closely that we can measure the tumor dynamics with a blood test, the better. If you try to do it with imaging, because imaging is, several months behind blood, you're way behind. Even if with whack-a-mole, the mole has gone back underground by the time you get your racket out. So with the new blood tests that we have, like circulating tumor DNA, those have been a real game changer, and oral medications that we can give to really control the dosing and the dosing intervals. That's been really important.
When I look back through my career in medicine on how we've managed breast cancer, there's a very dramatic progression of turning this into a chronic disease for many people. When I was in medical school, first you took the tumor out, then you took the breast off, then you took the ovaries out, then you took the adrenals out, and the patient died. And now for many women, this has become a manageable chronic disease. That's real progress.
Yeah, absolutely. And, I think you've had Walter Longo on.
Yes.
And one of the things that he's shown is that you can reverse treatment resistance using fasting. His fasting mimicking diet is what he uses to do that in his trials. And, that's another way that we can integrate, lifestyle into cancer management. And yes, breast cancer in many of its forms has become much more manageable. But we are using adaptive treatment in advanced metastatic breast cancer if we can find a good tumor marker, and we're actually alternating anti-hormone therapy with hormone replacement therapy to maintain bone health, cognitive health, and those kinds of things in very carefully selected patients.
Dawn, I'd love for you to talk a little bit more about fasting. I think it will be surprising to many listeners that the evidence for the value of fasting, especially before and after chemotherapy, has grown dramatically. Can you present that? And also, how do you talk to your patients about fasting? Because again, there's a little bit of counterintuitive. I think a lot of us have this idea of when you go through chemo, you lose your appetite, you lose weight, you don't feel well. And now we're going to ask you to fast on top of that.
Sure. So yes, fasting is counterintuitive when you're a child and you're ill, your mother, brings you food. That's the thing that you do when somebody's sick. You bring them food. Well, certain cancers, and again, we have to be really careful who we use these approaches with. It's not appropriate for everyone. It's not. So don't do this at home, but with your practitioners and doctors, you can explore this and you can explore it safely. Fasting works in cancer by protecting, it's the holy grail, it protects normal cells from damage from chemotherapy and radiation, and it enhances the susceptibility of cancer cells to those two things. So if you're going to have chemotherapy or radiation, you want to make sure that you've weakened the cancer cells by fasting. And in my opinion, and I think this will be proved, but I could be wrong. In my opinion, the secret sauce is lowering the blood glucose. It doesn't matter if you get there by fasting, by partial fasting, by, taking a GLP-1 receptor agonist, any way you can get that blood sugar down below 90 during your treatment, and lower is better, 70 is even better, the more damage you're going to do to those cancer cells and the more you're going to protect the normal cells. So normal cells are protected from damage during these treatments because they go into a dormant state. A cell in a dormant state is not dividing. Dividing and division, that particular state opens up all of the DNA in the cell. It literally unravels and fills the cell and makes a great big target for the chemotherapy and the radiation to get at and to damage. So when your DNA is unraveled and you're ready to divide, you're very, very sensitive to these drugs if you're a cell. Well, a normal cell, when the blood sugar goes down, says, oh, this is a bad time to divide. Let's roll everything up tight. Mm-hmm. Let's throw all the old furniture in the fire to keep us warm. And let's just wait till this famine passes. All right. And then, every cell is one or two cells from a blood vessel. So when the chemotherapy comes through in the blood vessel, they're battened down and they are not susceptible. And so they're safe. With radiation, the DNA is again wrapped up very, very tiny. It's not spread out in the cell. So when the radiation comes through, it's like cannonballs. It's much less likely to get hit. It can, but it's not going to be as much damage as if you had the DNA all spread out. Cancer cells can't go into that dormant state. Their DNA is spread out as much as they can. Their instructions in their, and this is a metaphor, of course, their mind is, we get to grow. We're going to grow at all costs. Whatever we need to do, we're going to grow. So every minute that you can, expand that DNA, get the division apparatus set up, and let's go, go, go. Well, when the blood sugar goes down, they still do that, but they get a little nervous, and they will continue to try to divide. But then the chemotherapy comes by, and they're like, oh, there's no food around. Maybe we should take that in and see if we can get some energy out of it. So they'll take the chemotherapy in and kablooey. So that's good. And also, if they take the chemotherapy in and and kablooey doesn't completely kill that particular cell, if there's no repair material around, lots of food, proteins, fats, vitamins, B12, they love that, B12. Mm-hmm. If there's none of that around, they will just eventually peter out and die. Okay. But if you put in food after your chemotherapy or during your chemotherapy infusion, what do the cells do? The cancer cells, they use it to repair the damage. So that's all work done by Walter Longo, who has, laid out how this works. And patients will accept fasting when you tell them that story. Mm-hmm. A lot of patients have fasted. Cancer patients are no longer very naive. They're pretty savvy. Before they get to me, they've done a lot of reading. They've listened to your podcast. They've heard Walter Longo. They know, that I'm going to tell them that maybe we ought to think about fasting. A lot of them have tried fasting themselves. And so it's, one of the things that I tell, student doctors, if they're thinking about using these things with their patients, is try it yourself. So I will, I've done a week-long water fast. It was hard the first few days. And then it became very easy, surprisingly. I followed my blood tests and watch the uric acid go up as it was supposed to, and all of that. And, so I understand from the inside what it feels like to conduct a very long fast. And so I suggest to physicians who want to explore that and are thinking about exploring it with their patients, explore it in yourself first. If you're able to, if you have, health that allows that, don't do it if you're not healthy and can't do it for some reason like that. But I think that if the physician is confident in what happens when you fast, what the first few days are like, what the last few days are like, most of the fasts around chemotherapy are 48 hours. That seems to be the sweet spot. Longer isn't as good, and shorter doesn't do anything. So 24-hour fast does not get the cells into the state that we just talked about. But a 48 hours fast, this is work done at University of Southern California, I believe, maybe City of Hope, in the late 2010s, found that in human patients on the most common types of chemotherapy, 48 hours was the best time to prevent damage to the immune system. They looked at something called the COMET assay, which looks at DNA damage in white blood cells. And also subjectively, of course, this is fuzzy, but patients felt better at that particular amount of time with fasting. So,
Dawn, I have a practical question on another subject. I have a longstanding interest in Chinese herbs that are used in cancer treatment.
yes.
If I tell a patient, if I recommend to a patient using a particular herb, say astragalus, for example, I often tell them probably best not to mention this to your oncologist, because more likely than not, they will be told not to take anything during their conventional treatment, including all supplements. How do you feel about that? Is that changing?
I get this all the time, and patients will say, I don't want to tell my my treatment team that I'm doing this or that. Usually I'm on the treatment team, so that's not, an issue for me, but it's difficult. I tell patients that I think honesty is the best policy. And one of the reasons is that it gets, standard oncologists used to the idea, hey, your patients are doing this. If you don't want to know about it, that's to your detriment and to your patient's detriment. You need to have a patient-facing persona that accepts whatever the patient tells you and deals with it. It's not about you, it's about them. And this is what, and you can tell them, I don't know very much about it, which I think is becoming the more honest answer. Not that there's no data. It's that, well, I haven't read that data. I'm too busy with my standard stuff. And, so I tell patients, if they have a Chinese medicine practitioner, which I think is grand, they want to talk to me. That practitioner can talk to me. One of the things that I really do want to know is what's in that. And if the patient brings in a bottle and it's in Chinese, since I don't read it, that's not going to be very helpful for me or the patient. So, I want something that's translated, and I want to work together and closely and see what we can figure out with this patient. And we do this all the time with other specialties. So why not with Chinese medicine? I'll call up ENT and say, what should I do with this patient's ear? So what should I do with this patient's Chinese herbs? Tell me what it is and why you're doing it and all of that. So I think that open dialogue, and I know this is idealistic, but I think open dialogue is what I want to push toward. And patients, this is going to be a little edgy, but if you're a patient and you feel that you can't be honest with your oncologist, is that the oncologist you want?
Right. Yeah.
Yeah.
Really? Would you want to rethink that maybe? And I know that it's not that easy to change. I get it, but I want to at least get that question out in the open. And yeah.
Dawn, you've spoken a bit about short-term fasting, about this adaptive treatment plan. You also offer some less conventional treatments like hyperbaric oxygen and temperature manipulation. Can you talk about those, and how do you decide when to put those into practice?
Sure. So let's start with hyperbaric oxygen therapy. And hyperbaric oxygen therapy has increasing evidence, although it's not perfect in terms of the evidence base. But there seems to be some evidence for certain patients with triple negative breast cancer, especially if they're on a drug called Trodelvy, because there's a nice interaction there. There may be some benefit in patients who are fasting and have a KRAS mutated GI tumor. Adding hyperbaric and also high dose vitamin C in those situations might be useful. And this is not strong evidence. And I don't want people to feel like, oh, if I can't do hyperbaric oxygen therapy, I'm missing my chance. No, but if you can and you want to, and it's safe for you, it's something you might explore. And some other things, sauna bathing is something I don't use. I think you were maybe talking about hyperthermia, where you aim microwaves at the tumor or something like that. I don't do that. I just don't have that equipment. That's a big deal. There's a center, UCSF off and on offers hyperthermia in their radiation oncology department. And then there's a place in British Columbia. Those are the places I know of on the West Coast that do that. But there's whole body hyperthermia where you're kind of sedated and you're put into an oven, basically, and your body temperature is brought to 105 degrees central, your core body temperature. That's really a real serious endeavor and procedure. It needs to be done by a physician who's very, very capable in that. I don't do that. But I do recommend for a lot of patients sauna bathing, and I recommend that they get their core temperature as measured under their tongue up to 101 to 102. And that takes a Finnish sauna, typically not an infrared, just because they're not hot enough. Takes a sauna that's at least 170 degrees Fahrenheit to get you there within a short period of time. And you want to measure, do not take a thermometer in the sauna with you. It'll just go straight up to 180. But leave it outside. When you think you're hot enough, get out, take your temperature under your tongue. And when you've hit 101 to 102, you're there. You're done. You can get out if you want. You can stay in if you want. That's the goal. You want to get there. And the thinking behind that, and this again is not proved science, but there's enough hints to my mind to say, well, it's certainly not harmful for most people and it might be helpful. So that's something that I like to recommend. The sauna bathing has to be done quickly. The heat has to rise quickly because the cancer cells can't make the proteins that protect them from heat damage very quickly because they're so busy. They have to turn off all the busy division part of things and go make some heat shock proteins and things like that. It takes them about 30 minutes. All right, literally. Okay, at least in the test tube. So if you get your body temperature up in 5 to 10 minutes, you're going to, trigger the death of some of these cancer cells. Normal cells, because they're not all busy with all of those other things, can trigger the production of shock proteins pretty quickly in 5 to 10 minutes or so. So they protect themselves. And also in normal cells, you can condition that response so they get better at it. And so that's why an infrared sauna, as beautiful as they are, cannot do what a Finnish or traditional hot rock sauna can do, which is get you hot very, very quickly. And then cold therapy, contrast therapy, it's sometimes called. It doesn't have to be fancy. Just in my backyard, I have a little sauna and I have a stock tank. It's 100 gallons, I think, something like that. It's just basically a big Rubbermaid bucket. And fill it with my garden hose. I do use a RV drinking water level hose, so I'm not getting a lot of plastics and things like that. But I don't think that's a huge deal. I just was able to do that, so I did. But jumping in the cold plunge or taking a cold shower immediately afterwards is a really good idea. You don't have to get an ice bucket and you don't have to get one of these $10,000 repurposed meat freezers that you see people buying. Please don't do that. My Rubbermaid giant dishwashing bucket costs something like $50 at the local Grange hardware. So I do recommend that. And 3 times a week is where you start seeing benefits statistically. Up to 7 times a week, the benefits keep increasing. So I do recommend those. So did I think HBOT, sauna, and I put in vitamin C, I think, high dose.
Yes. Well, I mean, it is always interesting to talk with you and to learn about the way in which you're tracking these innovations that could be really important if you have a difficult to treat cancer. You mentioned that if you have a highly curable cancer, going the conventional route might be just fine. But when you have one that's metastatic, that is not currently able to be cured, these other therapies that are coming onto line could make a tremendous difference in your lifespan.
Yeah, and that's exactly right. And I want to make a really clear distinction here. If you have a curable cancer and you use an adaptive approach, you're making your situation worse. So these are not things that you would transfer from the metastatic scenario to the curable scenario at all. And so anyone who has a curable cancer, if your doctor says, we can cure this, go with it. That's what you need to do. If your doctor says, oh, well, this is treatable but not curable, ding. You can think and explore the idea of adaptive therapy. It may or may not be right for you, but that would be the first clue that it would possibly be an option for you.
It is wonderful to talk with you. I also want our listeners to know that our center has developed a free resource for people who are newly diagnosed with cancer. It's on our website. It's under the Health Hub tab, and you can scroll down to find the Can Heal Toolkit. So that can be one other resource that people can find and make use of. Dawn, it's just been wonderful to have you as a guest on Body of Wonder. Thank you.
It's my
Thank
pleasure.
you.
Thank you for having me.